name is Chris. I'm fourth year. I'm going to be talking about hypo and hyperkalemia. Alrighty, so start with the case. I have a 6-year-old male. He's got a history of diabetes, hypertension, hyperlipidemia. He's presenting with flu-like symptoms for 3 days. He endorses 3 days of coughing, productive, white sputum, runny nose, stuffy nose, subjective fevers, abdominal cramps that are diffuse, nausea, vomiting, about 15 episodes, non-bloody, non-bilious, diarrhea, also 15 episodes, non-bloody. He feels weak, tired, and also endorses some muscle cramps diffusely. No chest pain, no trouble breathing, no travel, no sick contacts. Among his medications, he does take Lasix. For simplicity, we're going to assume this is not COVID. Examination-wise, vital signs are within normal limits. He looks very well. A little bit dry. Lungs are clear. His belly is a little bit tender diffusely, more so in the epigastrium, but it's not peritoneal, not distended. Extremities well perfused, just a little bit tender diffusely, but no rash, no edema. In terms of your differential so far, well, at least the most likely diagnosis, I think most people would probably agree that you'd be most concerned about something simple like acute viral gastroenteritis, but your differential might include pneumonia, bacterial gastroenteritis, influenza, myositis, acute HIV, acute hepatitis, myocarditis, or some other intra-abdominal infection. All right, so you send your labs and you get a phone call from blood gas for a critical value. Potassium comes back to 2.1, and similarly on your BMP, potassium is 2.0. Let's assume that the rest of your labs, everything not represented here, everything else is unremarkable. What do you guys think? How would you interpret these labs? You just shout it out. Pretty straightforward. Hypokalemia. All right, so hypochloremic, hypokalemic, metabolic alkalosis, right? In this patient, due to significant GI losses, vomiting, diarrhea, as well as being on a long-standing loop diuretic, RACE 6, it's going to confound the hypokalemia. So for hypokalemia, there's many different causes, but simply put, most common causes, the ones that you're going to encounter the most. So for intake, not super common, but you might see it in your anorexic patients or your alcoholics. Excessive loss, whether it's GI or renal. So like in this patient, GI losses, vomiting, diarrhea, and then renal losses. A lot of our patients are hypertensive, so they're on diuretics, whether you're on a loop diuretic or a thiazide. Those are your clinical K-wasting diuretics. And then hypomag. Any alkalotic state, remember your relationship between your hydrogen ion and potassium, it go in different directions, opposite directions. So if you're alkalotic, you're going to be pushing out more hydrogen into your blood and consequently taking out more potassium into your cells and becoming hypokalemic. And also keep in mind that there's a very close relationship between potassium and magnesium. Oftentimes your hypo-K will be accompanied with hypomag. So when you're depleting your potassium, your reabsorption of potassium might not be optimized unless you're also depleting mag at the same time. So oftentimes we'll give K and mag at the same time, even regardless of whether you know your mag level or not. This patient's EKG, remember their K is 2.0 or 2.1. Any takers? And also just shout it out. You don't have to go systematically, just anything you see.
Pro on QT, U-wave.
Someone said U-wave.
Depressant.
Someone said antidepressants. All right, good. We'll come back to it. So usually you don't get EKG changes until the K is pretty low, like 2.5, 2.7. Your EKG changes are as above, so increased amplitude of your P wave, PR prolongation, flattening of your T wave that goes into inversion, ST depressions, U waves that most oftentimes occur in your precordial leads. This is probably the most unique or distinguishing EKG feature for Hypo K. And then lastly, something called a long QU interval. Among these changes, they don't necessarily have to occur in this order. You can have one, you can have a combination. They don't go top to bottom. Although this last one, the QU interval, is probably the last finding. So you can see an example at you can see my mouse, but the bottom right figure, you see an example of a QU interval. So you can kind of think of it as a combination of the third, fourth, and fifth bullet. So you have ST depression, T wave inversion, your inversion blends into your Q wave, so it creates that QU interval. When your EKG machine attempts to calculate your QT interval or your QTC, it might mistakenly think that the U wave is actually the T wave, so it might give you a falsely elevated QT or QTC. All right, so going back to our original EKG, someone said ST depressions. You see them here. 2, 3 idea inversions as well. And then, of course, U waves in the precordial leads. All right. Why do we care about Hypo K? So you can have arrhythmia. So you can have PACs, PVCs, SVT, AFib, aflutter. But most importantly, what we really care about are the life-threatening ventricular arrhythmia, so VTAC, VFib, torsades. Remember that your main causes for acquired torsades are Hypo K and hypomag. Generally speaking, at least for me, I would consider anything above 480 as a prolonged QTC. My cutoff is kind of like 480. And then anything above 500 or 520 is particularly concerning. All right. Treatment-wise, pretty straightforward. You're basically just going to replete the K. So you can give it PO or IV. Usually I give potassium chloride PO 40, if they can tolerate PO. IV-wise, you can give 20. The rate for IV potassium is going to differ depending on whether you have a peripheral line or central line. Central lines can go twice the speed or twice the infusion rate. I think the recommended rate is actually still 10 per hour, whether it's a peripheral line or central line, but if need be, you can give 20 NEQs per hour for central line. And then again, as we talked about before, very oftentimes we'll give magnesium sulfate 2 grams empirically, regardless of whether you have a measured mag level or not. General rule of thumb is that every 10 milliequivalents of potassium that you give is going to increase your serum K by 0.1. But of course, be cautious with your renal failure patients who are not able to eliminate their potassium as well. All right, so our second case, this patient is 60 as well, 60-year-old female, diabetes, hypertension, hyperlipidemia, CKD, CAD, MI, CDA. It's coming in with a 3-day history of altered mental status. This woman is coming from home. It's not a nursing home patient. At baseline, she is relatively functional. Her mental status at baseline is 8 out of 10 straight. She does all of her ADLs. She lives with her husband. Husband says that for the past 3 days, she's been increasingly confused, not as interactive, quote unquote, not herself. And today, she's just completely unresponsive, not getting out of bed. Patient is ANO times 0, not talking, but just moaning and groaning. Husband also says that for the past 1 week, some coughing, fevers, trouble breathing, and that's again, assume it's not COVID. All right, so examination-wise, patient's tachy, tachypnic, hypoxic, and febrile. She looks very tired, lethargic, and dry. She is arousable to painful stimuli. She's in respiratory distress, and she has some diffuse crackles. This is your UVBG comes back first. Let's assume your potassium is not hemolyzed. Any takers?
High ion gap catheter.
Oh, thank you.
Metabolic acidosis.
Very nice.
With hyperkalemia.
Perfect. All right, so it's obviously a gap metabolic acidosis with some respiratory compensation. And this is your EKG. Patient has multiple pneumonia. Everything is going A-OK until shortly afterwards. Your patient seems to be decompensating, going into worsening respiratory distress. Patient becomes more hypotensive, more tachy, more tachypnic, more hypoxic. So you decide to intubate. Patient's on a monitor. You have your patient positions, give your RSI meds, and you're successful. You intubate the patient. However, shortly after that, post-intubation, you notice on the monitor that they're sort of doing that thing in the top right. QRS is widening, and patient loses pulses. So what do you think happens? So to review, patient severe pneumonia sepsis, right, with severe metabolic acidosis and hyperkalemia. You give your RSI meds. For a brief period of time, they're basically apneic, right? They're not breathing. So then their CO2 goes up, leading to even worsening acidosis, worsening hyperkalemia. So just as a side note, lesson to be learned is when you're intubating your severe metabolic acidosis patients, they are at risk of developing fatal ventricular arrhythmia, such as this. One way to potentially counter this is that when you put your vent settings post-intubation, you want to put a higher ventilation rate than your typical settings. So a higher respiratory rate or a higher tidal volume to blow off more of that CO2.
Chris, can I ask you a question?
Mm-hmm.
So that bottle shows rocuronium. Can you just comment why you use that instead of succinylcholine in this patient?
Yeah, definitely. So I'm sure you guys know that your main contraindications or main concerns for SOX are number 1, hyper K, which this patient already has, as well as malignant hypothermia. I think someone said that for anybody, you or me, someone who's relatively healthy, it's going to increase, SOX is going to increase your K by like 0.5. And then, you know, someone with like renal failure might increase it even more. So your EKG changes. First thing you're going to see are peak T waves. These are relatively in order, and then P waves are going to flatten and disappear. PR prolongs, and you can go into bradyarrhythmias. QRS widens. You can go into a sine wave morphology. And then ultimately the same fear complication as hypo K, VTAC fever. This is an example of an EKG with hyper K, so you can see peak T waves diffusely.
And the symmetrical.
And it's symmetrical. And it's global, right? So why would you think this is not an early MI? No reciprocal changes, someone said. But also, unless the patient's super unlucky, you know, unless they're unfortunately having like global MI, or global myocardial ischemia, it's more likely to be hypokalemia, right? So this patient's having a bradyarrhythmia. I feel like from my experience, most of my patients that are hyperkalemic, the most common bradyarrhythmia is just sinus brady. But you can have any bradyarrhythmia, including AV blocks. In this case, this is a functional rhythm. More examples, peak T waves. Hard to tell, but the PR is a little bit prolonged. QRS is wide.
Very well.
This is your sinus morphology. All right, so if you have this, what are you going to do? Your treatments. So the first thing you want to think about is stabilizing your cardiac membrane. You're going to get calcium. If you have, I would say if you have EKG changes or the patient is high risk for EKG changes, you should get calcium, whether it's calcium gluconate or calcium chloride. Remember, as Dr. Wiener said, calcium chloride, you need a central line, it's about 3 times more potent. And then secondly, you want to shift your potassium from the outside into your cells. So as a rule of thumb, you can give 10 units of insulin with a D50. Remember that insulin is excreted by your kidneys, so in your renal failure patients, you want to be more cautious. For me, usually I half it, so I'll give 5 units of insulin with the D50. And then you can also give albuterol, your beta-2 agonist. It's a much higher dose than people expect. It's 10 grams. Remember that each nebulizer is 2.5 grams, so it's basically 4 nebulizer treatments. Right, and then excretion elimination, you can give a K-wasting diuretic, most oftentimes Lasix, if they can pee, and then if indicated, emergent dialysis. In summary, your presentation for hyperkalemia, a lot of these symptoms are very non-specific. They can have weakness, palpitations, nausea, vomiting, trouble breathing, etc. Remember your ECG changes and your life-threatening ventricular arrhythmias. Generally speaking, your hyper K is much more dangerous and much more concerning than hypo K. And to summarize, hypo K, again, kind of non-specific presentations, typically like weakness or cramps, palpitations. Remember your U wave. Avoid your VTAC. Beat that into sides. And that's about it. Any questions?
Do the insulin doses change if they're insulin-dependent diabetics? Would you start at a higher dose?
So a lot of our patients definitely are diabetic. If they're insulin naive, I might give a lower dose, maybe like.
No, there's no such thing as insulin.
No, you're just trying to get the effect out of it.
Actually, if you think of patients who are type 2, right? What are their insulin levels? Much higher.
Yeah, they're insulin
right?
resistant. For
They're
type 2,
insulin resistant. This insulin naive is a myth. You give the same dose.
Yeah, you just give more glucose.
Yeah.
So my question is more about like if they're insulin-dependent diabetics because they're more insulin resistant, and it's at 10 units, would you start at like 15 or?
Insulin-resistant diabetics aren't more resistant. They have less insulin.
You don't really change it.
No.
I'll start with 10, yeah, and then give more if needed, but start low, start with 10, more is needed,
The biggest thing here is you need to recheck and re-give, because these aren't like lasting treatments. They will subside and that K can persist. So you have to recheck it.
Chris, did you see the paper that came out about probably 2 or 3 years ago that said people with hyperkalemia who would hemolyze, as long as they have a normal creatinine, you don't have to repeat it. They've never been shown to have real hyperkalemia or dangerous hyperkalemia.
That's false.
Oh man, I don't.
It's just false, because then you miss the hypokalemic patients.
No EKG changes, do you think it makes a difference?
Yes. I wouldn't do it.
Also, people who are on medications that raise their potassium, they don't necessarily have their desire to have real hyperkalemia.
I think you missed the low patients. That's what I always worry about. When it's hemolyzed, how do you know they don't have hypokalemia? Just got hemolyzed to a normal level or an elevated level. I read that paper. In fact, I wrote a letter to the editor saying that was wrong.
We'll never get another article published in that journal.
No, they published my letter to the
Yeah,
editor. They
Dr.
agree.
G and Dr. Hassel, Dr. G.
So,
Just two quick comments.
Okay.
So Dr. Lin mentioned for hypokalemia, that rule of thumb, 10 milli equivalents, increase your potassium by 0.1. But in practice, and when the interns when you do your ICU rotation, you'll see when you're treating these patients in the ICU, it very infrequently rises the amount that you expect it to. So if someone's really hypokalemic, you have to give them way more than you expect, at least double the amount that you expect. You're not doing it all at once. You have to do it over time. You're still going to give 40 or 60 PO and 10 or 20 IV, but you have to constantly keep giving it, because when you check your next potassium, instead of it raising 0.8, it's going to go up by 0.2, for example. So you have to be very, very aggressive with repletion with this potassium.
Make sure you give magnesium too.
And yeah, make sure, same thing, that you're constantly repleting your magnesium, same concept. And for hyperkalemia, Dr. Lin mentioned, if you're intubating a patient, you want to have a higher tidal line or higher respiratory rate to make sure that you are still replicating that respiratory compensation. So a good rule of thumb is whatever their respiratory rate was before you intubated them, you can potentially start them on that same rate. It's not ridiculous. They're breathing at 45, I don't know if they put them at 45, but if they were to get them at 30, you might want to start the respiratory rate at 30 until you get things under control and know that you're balancing out the metabolic acidosis with your appropriate respiratory alkalosis on it.
Let's do Dr. G and then we'll move on.
a few comments. One, about using the insulin for hypokalemia. Just be very careful to follow your patient, because you give it with D50, but insulin is excreted in the kidneys, and if they're in renal failure, that insulin, that regular insulin IV you're giving, is going to hang around a long time. And so some of those patients may become hypoglycemic on you just from one D50. So when I do that, I often, for the first couple hours, we'll get finger stick dextrose every hour or two and watch them. And if need be, give them more D50. The other thing, I was just going to ask you a question about, let's say you can't get dialysis, you treated them for hyper-K, you know now it may bounce back, right? Because what you're doing in a lot of these cases are shifting, right? You're shifting from the blood into the, away from the heart. So is there something else you can do to them until you can dialyze them that may get the potassium out of the body?
So you can either get rid of the GI or renal or urination. So diuretics, talk about Lasix or any of your K-wasting diuretics, and then GI-wise, I didn't go into it.
Don't say it.
I know.
Don't say it. Do not say that word.
Oh,
the other binders. Yeah, Partamia.
Oh,
Partamia works, not K-Excellent.
oh,
But Partamia works. And we have Partamia on both sides of the street.
Yeah.
Yeah.
Awesome. Thank
all right,
you.
next question.